to focus on was improving our culture of safety. Does anyone remember taking the culture of safety survey last summer? We usually do it in July or August every year as a hospital. Anyone remember? It's about a 50-question survey that asks you questions about like how comfortable do you feel raising safety issues in the organization? Do you think the organization values safety? That kind of thing. It's actually a nationally standardized survey that's produced by ARC, the Agency for Healthcare Research and Quality. Is that it? Oh, look, I got it right. So what we said is, well, we want to prevent these serious safety events, and there are some opportunities we identified in this survey. So we said we have to work on our culture of safety, and to actually define what that means, it means embracing a common mindset where safety is at a core value in all of our work. So not just in our clinical work, but on the administrative side when we make business decisions or strategic decisions about the direction to take a hospital, is how is this going to impact safety? So why focus on the culture of safety, and specifically this particular intervention? We have been working with a national collaborative, the Children's Hospital Solutions for Patient Safety Collaborative, for about a year and a half now. And that's my job. I work with the collaborative, and I'm on liaison with them. And so the original members of this collaborative, about 13 hospitals out of Ohio, implemented this communication tool set in their hospital. And so what they were able to do is they introduced this tool set into the hospital, and what they were able to do is dramatically decrease their serious safety event rate. And a lot of these hospitals have actually been able to sustain that performance for 2 to 3 years. So it's a pretty powerful statement, because usually when you try some of these interventions, which are difficult because they're the soft skills, they're not the technical skills you teach your hospital and your physician staff, you'll see a blip. And so we felt that this was a really strong impetus to move forward with this. So what is Mission Zero, and how does it help keep our patients safe? Mission Zero is really an aspirational goal for the hospital to prevent or to eliminate all preventable harm. So to give you a context, whenever we have a serious safety event, they usually do a root cause analysis. Have any of y'all ever participated in one? Usually they identify anywhere from 20 to 30 causes for this particular event, and usually about 2/3 of them are behavioral communication based. Someone forgot to speak up, someone was too scared to speak up, those kinds of things. So the aim of this tool set is to hopefully empower our staff to be able to have the communication tools needed to help in those situations. So as part of that, we implemented the error prevention strategies. And so if anyone, and from what I understand, the Department of Pediatrics onboards all of the residents with team steps, is that correct? It's very analogous to the team steps tool set. So unlike all the other hospitals though, so there's now about 83 hospitals in this collaborative, and they're putting all of their staff through 3 to 4 hours of classroom experience. We decided on a different deployment method, given Epic and a lot of other things going on in the past year. So what we decided to do is cut up these 8 tools, only focus on 1 to 2 per month, and turn it into a continuous cycle. So we have some vehicle to have a continuous discussion about patient safety every month forever. And so this has been supported by leader roundings. We've had scenarios and exercises built, integrating them into our current processes, and then everyone has to take an annual health stream refresher. And our executive team actually felt so strongly about this work that they put 2 of the 7 goals about this work. So the first one is to ensure that 75% of our clinical areas have been implemented and are long-term training on this. And then these are the 3 questions on our culture of safety survey we're looking to impact. The first is staff will freely speak up if they see something that may negatively affect patient care. Staff feel free to question the decisions or actions of those with more authority. And staff are afraid to ask questions when something does not seem right. And to give you some context, we were probably anywhere in the 10th to 30th percentile on those questions. And that's kind of scary. So basically, when you guys are caring for your patients, there are people that may be your peers above you, or the nursing team that you're working with, or the respiratory therapist. And if they're not feeling this, and they're not going to speak up at the right time, or they may not know how to speak up. So this is just to give you a little glimpse of what our cycle looks like. We decided to even change the order of the tools in which we talk about them to account for things like Epic, or when residents are coming on board. If you ever want to know what the tools are that we're focusing in on, just look at the screensavers. They're actually timed, so they kind of coincide with what's on here. And on the main page of the intranet, there's a rotating banner that actually has what there's also a Mission Zero intranet page that has more information on there. So for example, the ones that we're focusing on this month are question and confirm. So again, when things seem awry, question is your internal check that tells you something might be wrong. And I always like to think of Spider-Man, my spider spends is tingling. Am I the only one who gets it? And then question and confirm, your external check, you explore the situation. So this is not a novel concept, but part of this work is getting things that we all have already known to do or learned to do probably decades ago, and putting a name to it and encouraging staff to do this. So I think I may have already skipped ahead a couple of my slides. And the other thing that we're working with our staff right now is to have a lot of our management team practice and call this out in non-critical situations. So when there is a critical situation, people already have that memory to use these tools and these terms. So the other one for this month is stop and resolve. So that's basically if you see the potential for an error, stop what you're doing and resolve. Take ownership of ensuring the situation is addressed. My favorite example is actually from Ann McCune, who's our Chief Operating Officer. When she started here, I think it was her second or third month, it was Christmas and she had no PTO. So she said, well, I'm gonna be here all Christmas, and she was here all month long, and she actually put a Diet Coke can out on the stairs to see how long it would take for someone to stop and pick up the piece of garbage, and it took 4 hours. So, I mean, even on a small thing like that, you know, we want to be the organization where people see a piece of garbage and they stop and pick it up. When they see there's a patient care issue, that they stop and resolve it. So I got a really great example actually from our head of respiratory therapy, Mike Henry. There was a nurse in the ICU who kept silencing the alarm on the vent machine and didn't even look in to see what was going on or questioning why is this alarm keep going off. And then the patient ended up coming, and when respiratory got there, they found out that one of the tubes had been unplugged. So had the nurse actually paid attention to the alarm and looked into the situation, could have possibly prevented the code. So we're trying to talk to staff about some of these events where they use the tools and you have a much better outcome, or even in the events where we had a safety event, to talk about how could the tools been utilized to prevent these types of events. I think. So we have some resources available. Like I said, on the intranet, we have a rotating banner that tells you what the tool of the month is. For the Peds and the OB residents, we actually have a physician champ. So for pediatrics, the Chief's blog gets updated once a month, and then they also do a blast to all the pediatrics residents. For OB, I know Dr. Susan Crow, I work very closely with her, and she works with all of her residents. They even have like a little box where they put in like the examples of how they've utilized the tools, and they do drawings for the OB residents. And again, on the intranet page, there's some really cool stuff there. We have some videos from Nationwide Children's about how they show how the tools have been utilized in both clinical and non-clinical settings. And they're pretty quick. They're only like a minute each, but they're pretty informative. And then what we've also started to do this past month is, as examples come into our quality department, we've been posting them on the intranet and showing how some of the tools either were used or could have been used to have a safer outcome for our patients. Oh, and also a peer review process. So I thought this was actually pretty interesting. So during the peer review process now, if a case comes up for review, when each of the little committees meets for each of the departments, they actually go through and talk to the physician about how they could have utilized these tools, or they even reward and recognize the physicians when they have utilized them. So I think it's actually a really great sign of penetration to our physician areas. And then I'm working with our case management, about incorporating this into family-centered rounds as well. So, does anyone have any questions or feedback about this work or what we're doing with it? Yeah. So it's anything from retaliation from peers, retaliation from physicians, across clinical disciplines. I mean, it's any way you can name that kind of pressure. I've heard people voice concerns and examples. The good thing is we've had really strong support from our leaders. So on the few occasions where since implementing this, we have had some undesirable behavior. We've had proper channels to escalate those types of concerns, and they've been dealt with pretty quickly, because we really want this to be a place where people feel comfortable going to work, where if you ask a question, it's because you're trying to do it in the patient's best So
implementation?
for that one, it's mostly the focus on looking at the processes that we have in place to prevent the hospital-acquired conditions. And literally, there's like a very complicated card for many different processes that we check in on the nursing side. And just working with the nursing to identify, what are the barriers to following these processes and procedures. Is it coaching opportunities? Is it, looking at the equipment that we have in the room and things like that. For something like on the OB side, so one of the things they were working on is postpartum hemorrhage. There actually weren't any clinical interventions that they did. They actually worked very closely with our performance improvement department to actually look at, well, do we have everything we need and all the right things in the room to respond to hemorrhage when it occurs, so it actually doesn't turn into, I think the definition is postpartum hemorrhage requiring 4 packs of thank you. I'm not correction. But what they did in that is they literally looked at, well, how long does it take us right now to respond to hemorrhage? And for that one, it was about, I think it was about 3.5 minutes initially, which is kind of scary. And so what they did is they looked at, well, do all the rooms have the right equipment? Is it positioned in a way that they can start accessing it very quickly? They even moved stuff around on the unit, not just in the rooms, but around the unit itself. And I think they got the response time down to like 20 seconds, something like that. And we went, just in that measure alone, we reduced our postpartum hemorrhages by like 80%. I mean, it made a huge difference.
Yeah, no, that's awesome. I was just wondering because 40% is what my understanding is that goes for everything, right? All of it.
Yes, a cumulative that individual.
Contributed to all the different costs. Right.
Yeah.
So it's not comparison.
And yes, yes. On some of them, it is a little easier. We haven't actually.
I'm only asking this because
Oh,
I'm
sure.
trying to implement something and trying to figure out a basic value, and I was like, well, it's so hard to do.
Well, we do. So the data is available. We actually haven't sliced it that way. So we actually have data on every individual little process check that's done, and then we probably could correlate that to the outcomes. So it is available. We just don't usually go that level of granularity because there's, on some of them, I think there's up to like 16 measures we could attribute to a particular app. But no, yeah, the data is there. And it's good. Good question. Anything else? Thanks for your time.
Thank you, Jose. Applause, applause. Bow. Encore.
Yeah.
What time do I have until? As much as I want. No, you don't want to give me that option.
Look at these faces.
Is it till 5:15 or 5:30? I'll see if everyone's asleep by 5:15. And we'll see where we're at. I have enough that I could take us till 6, so I won't do that. We'll have a couple of stop checks there. For those of you that don't know me, my name is Terry Platek. I'm a pediatric hospitalist here. I trained at the University of Michigan. I did internal medicine and pediatrics. I'm the medical director in our performance improvement department, and I have the pleasure of, I guess John is the only one who's here today, of being the fellowship director for some of you guys at Stanford's Clinical Excellence Research Center, which is a center devoted towards innovative healthcare process redesign that lowers the cost of care and improves outcomes and improves the patient experience. But today what I'm here to talk to you about is mostly performance improvement in healthcare. And Jose foreshadowed a lot of what it is that I want to talk about. And for those of you that were residents here, I apologize. You may have seen some of these slides before, but these would be the goals if we get through everything today and we don't have to get through everything today, but that I want people to kind of leave with. And the first is that systems have a great effect on outcomes. I think the previous discussion, if that didn't convince you of the fact that it's not so much as always knowing what it is you have to do, although you do have to know what you need to do. It's also important that you actually get done what it is that you designed to do or you intended to do. And systems have a very important effect on that, on those outcomes. Healthcare systems tend to be very complex. I'll give you some information about that, and I'll say that physicians, my operating thesis is physicians in particular, I think physicians in training can contribute substantially to the redesign of healthcare processes for more reliable healthcare systems, and that problem solving using daily management results in better patient outcomes. So, those of you who've seen this already, don't answer, but for those of you who haven't, what might be wrong with this picture? So for those who don't remember, it's a or don't recognize, it's a bathroom on the third floor. I took it about a year and a half ago. Dr. Ross. You are a very smart young lady. And so one is the soap dispenser, right? The soap, and the other is the foam waterless hand sanitizer. Why waterless? Two reasons. One, you don't need water, right? And the second is, if you use water, it doesn't work, right? You have to have a certain concentration of the stuff to kill the bacteria. If you actually ever put that stuff on your hands and you use water, like it's like an oil slick, like the water just takes it straight off your hand. The stuff needs to be on contact on your hands for 15 seconds in order to achieve the killing of the bacteria that you want. By the way, that's our standard for hand washing in our organization. 15 seconds. I just wonder why you can never get enough goop on your hands to actually allow you to continue to do 15 seconds of hand hygiene from one actuation of the device. That seems a little weird. You like do it, then it's like 7 seconds, you have to go back and get some more stuff, right? Why not design it so you get enough goop for 15 seconds? Because you probably keep rubbing your hands until they dry, right? Yeah, I never understood that. If anyone wants to go into a company with me that design one of these things that actually works, let me know. But this isn't our bathroom. Okay, so how many of us think that it is okay to stool, clean yourself, and then not wash your hands? And I mean wash your hands with soap and water. We all think good. We're all on the same page. You gotta wash your hands with soap and water after doing number 2, right? So why put the foam handless? You can't even see the difference between this. I mean, literally, like you're standing there, it's very hard to tell what's what. But this was in our bathrooms for a year and a half. I mentioned it, I don't know, about once a month. Finally, thanks to Susan Costello, she said, that's it. To the engineers and said, you are searching room by room and getting rid of all these hand sanitizers in the bathroom. What about this? Does anyone remember when this was going on? They were doing a little bit of work out there, right? It's before they put one of the air-proofing devices, which is now there's a carpet if you actually walk out. And now we have less people bringing water in and slipping and sliding on that floor. But I was walking out here, and I took this picture a few minutes, maybe 2 minutes after I nearly got run over by that car. Because I saw a caution sign and a bunch of stuff, and I saw a ramp, and so the ramp's pointing me this way. So without thinking, I just walked where I'm supposed to go, right? Caution, don't go here, right? Go this way. Of course, I walked into traffic, right? Humans are habits of systems, right? And if you design the system for failure, smart people, I consider myself not stupid, will do stupid things. The baseline human error rate for something that we do really well is 1 in 100. Like you could be like the most amazing basket weaver, but 1 out of 100 times you're getting that basket weaving going, you're going to make a mistake. It's just the way human systems are. And so the question is, in healthcare, have we elevated ourselves beyond that baseline human error rate? Does anyone remember when they were doing a little bit of construction out there? This was in front of the clinics, out in front of 731. So they were having issues with the crosswalks. You might still be having issues with crosswalks. Can anyone tell which way to go? Do I go with a taped over black arrow that no one can see, or do I go with the original white arrow? And then, by the way, this kept switching so often, and they didn't keep it up to date. And we expected our patients to be able to figure out where to go. Some people may notice, and that might be Dr. Ross, right? No, I think it's Dr. Frankovich. But in any event, how many people do you see crossing the street right here? A lot. Someone's going to get hit. Right? It's going to be on the news. I hope. So why not put a darn crosswalk here? Right? Why? Now, the reason why is, I've gone after this, is because the city won't give us a crosswalk there. Because we decided to put a turning lane there. But it is infuriating to me that people are just, oh, okay. And so our solution has been to put a sign there, right? So what I'm going for right now is to put a big fence so that people can't do it. What I'd like to be able to do is make it easy to do the right thing. Put a crosswalk where people are across the street. Or, oh my God, you're blowing my mind here. Yeah, there's other options. So as fellows, you guys don't do any work overnight. No. I don't know if this guy does though. But at 2 a.m., do you think he'd know how to get one of those outside CTs put into CERN so that the next morning someone can be looking at those studies? No. I don't know how to do it. I don't think you can. Maybe if you run down all the way to Stanford, you bribe someone with chocolate, and then you bang. then maybe they'll do it, and there's a 50% chance that they'll do it correctly. You'll probably never see the disc again, and the family will be really upset at you because that was their only copy of the disc. And by the way, they just had a traumatic experience finally getting over to here, and all they've been told the entire time was don't use this, right? Because to get another copy of that disc, they have to go back to Soledad, right? And pay another $15 for someone to scan on that disc, circa 1992. So, as I'm hoping that everyone believes, systems have a great effect on outcomes, and it doesn't have to do with the knowledge always that's in our brain. And I think healthcare systems are very complex. So how many of you have ever had issues with the safety or efficient care of your patient? So we have near 100%. By the way, everyone keeps noticing I'm looking back this way, right? What would be the solution? I don't know. I don't ask. Well, the solution actually, per design, is that I should give the lecture from here. Right? Now, maybe actually that's what I'm supposed to do because there may be someone up there that's trying to videotape me. But that's the solution, right? So basically the system's designed that I'm supposed to give the lecture from this point. And I should just stand there the whole time and do exactly the way the system was designed. It's just like some of the engineers that design electronic health records, right? Just do it the way I told you to do it. Not the way you need to do it. Just do it the way I told you to do it. Click down 18 different times, and then you'll find out where it is. Didn't you read the instruction manual? So I've had problems with issues with safety and efficient care of my patients, and so have many others. And in 1999, the Chair's Human Report was published, and this described that in the United States, there are 100,000 deaths annually in hospitals, pediatric and adult hospitals, that are due to an error in healthcare systems for which the medical record on subsequent examination demonstrates that the healthcare system would be found liable if it were brought a suit. Right? So this isn't just 100,000 deaths. This is 100,000 deaths where we recorded that we caused the death in the healthcare system. It's better in Peds hospitals than adult hospitals, but it's not great. And unfortunately, this problem isn't better in Peds hospitals. It's just pediatric patients tend to be more resilient, and that is, in 1999, we believed that preventable injuries affected patients, 3 to 4% of hospitalized patients. Unfortunately, that number is actually much higher. I'll go into that in a little bit. But this is that baseline data that Jose was describing to you guys a little bit earlier. And the baseline data shows that we were having around, there's arguments now whether it was 12 or whether it was 14 bits and how you calculate the numbers, but these are the number of HACs, hospital-acquired conditions, per month we were having. And those include CLABSIs, CAUTIs, VAPs, VTEs, falls, surgical site infections, OB adverse events, medication issues, pressure ulcers. These are things that people didn't have that they're coming in and we're doing to them. And that's happening about 14 times a month at Packard. And through a lot of work, we've been able to reduce those numbers. But this is pretty common across the United States, despite the fact that about a decade ago, a guy in Michigan, Peter Ponevos, published an article that said, you don't need to have any more central line infections ever again. If you just did this sort of stuff, we've shown a couple hospitals that have gone years, not in an ICU not having infections, in a hospital not having central line infections. We do a lot of that stuff here. I'm not saying that we don't, but we still have a lot of issues with breaking into lines a lot, right? Because we are changing orders and the way we have systems set up. And so, congratulations, Dr. Tracy. Right. How safe are we as an organization? I'm sorry, as an institution in healthcare? And this is looking at basically error rates in various industries. And so ultra-safe industries talk about parts per million, parts per billion error rates, right? And in healthcare, in many cases, we're talking about error rates in the 1 in 10 or 1 in 100. If you call the IRS 140,000 out of a million times, they're going to give you the wrong advice on the tax preparation line, right? If you go to a hospital, according to the IHI Global Trigger Tools, 450,000 out of a million times you're going to get injured in the hospital. If you look at it across various elements, this is from Annals in 2005. If you look at medical risk total, we're maybe getting close to 1 in 1,000. A lot of that has some air proofing and anesthesia and so forth associated with it. But if we're talking about sicker children, we're talking about error rates in the 1 to 100 range. If we're talking about really well patients with getting general anesthesia, there's been a lot of work to make it such that they don't happen what happened in the 1970s, which is you give a child oxygen and you find out you've hooked it up to the carbon dioxide on the wall and they asphyxiate. Finally, make it that we can hook up the carbon dioxide to the oxygen, and then they made a physical interlock. You can't do that. Sort of like, in theory, if you don't use a cord and wrap it around your lawnmower, right? When you take your hand off the handle, right, the lawnmower shuts down. So you can't stick your hand in the lawnmower and cut your hand. You can't start your car on in-drive. That's what it is. So this are just some of the various studies looking at where the results are across our industry. This North Carolina harm study was in the New England Journal. Paul Sherrick, our medical director in quality, published this study, which described an 18% harm rate, and as I mentioned, there's some as high as in the 40s for harm rate. And so if we look at the cost of care in the United States, we might think that we're doing okay, and the answer is unfortunately we're not. In the late 90s, our cost of care was up there, but it wasn't the absolute highest. And in the mid-2000s, we had become the highest cost of care. I'm sorry, this is mortality. I'm skipping a slide. In the late 90s, we weren't the worst in terms of attributable mortality. But since then, since the mid-2000s, we actually, among many organized and industrialized nations, we are worse when it comes to mortality. And if we look at, let's say, France and Australia, and we look at the cost of care associated with their cost of care, total expenditure per capita in the United States is around 3,000 to 4,000, and this was in 2008, where it was at 7,000. Right now, we're around 18.5, almost 19% of gross domestic product. That's close to $1 in every $5 in the United States. In the United States economy is spent on health care. Pretty soon we will not have enough money for Social Security, an army, education. It'll just all be eaten up by health care. With trends that have only recently started to take a little bit of a turn, unclear why Obamacare versus the economic downturn. But traditionally, 7% a year is what we're passing on. It's what Packard, by the way, has been passing on to insure 7% increases per year. No other industry has been able to survive passing on annual increases in costs of care. Right? If a PC costs more today than it did 10 years ago, how many people would be buying PCs? Right? It's interesting. So let me skip past that. This basically just goes to show that if we're looking what our $2.7 trillion or 18% of GDP is being spent on, we can see the average prices for things in the United States as compared to other industrialized nations is quite different. And by the way, the cost of care between various geographic areas in the United States can be as much as tenfold different, right, for the same thing. So this is from the 2012 Institute of Medicine report, and basically Berwick said in this, and he tried to categorize where are these excess costs being spent, right? And if we look at, let's say, unnecessary services or inefficiently delivered services, we're not talking about billions of dollars or tens of billions of dollars. We're talking about hundreds of billions of dollars, right? We're talking about the size economies of states that are being spent on stuff that patients don't need or inefficiently delivered service. And so if we look at this in another way, we would say, okay, if the cost of healthcare rose at the same rate as the cost of some basic food in the United States since World War II, how much do you think a dozen eggs would cost? $55, very close. Milk. $48. Oranges. Overcorrecting. $134. So, bowl of oranges. I don't know why oranges ended up being quite that high. But I think they just cost a lot. There's something about the war or something. But nonetheless, right? If we went to the store and had to pay $55 for a dozen eggs, that would probably be a benefit. But that's what's happened with healthcare. So that's our burning platform. And that's why I do performance improvement, and that's why I care about not only improving outcomes, but trying to do it in a way that actually reduces overall burden and thereby reduces overall cost. And so we'll spend the next 10, maybe 15 minutes, get you out early, just trying to get through the next two, and I'm going to skip a lot. Okay. So this is the basic value equation. If you haven't heard it before in healthcare, here's your first entreat into it. Value is quality over cost. And we talk a lot about quality of care.